instead of general.
Tailored, true.
Specific instructions rather than
General versus specific. A nutritional counseling should really take place in multiple visits. In a hospital setting, I'm probably, the person that has a brand new diagnosis for diabetes, probably the last thing I want to do is go in there and give them a 45-minute lecture on what they need to do now in terms of counting carbs and keeping track and monitoring and doing their blood glucose and doing everything that they need to do. It needs to take place in an outpatient setting is where it really needs to take place. I can send them home with some survival skills, but I will never forget the first time I went in to educate a person, a newly diagnosed person with diabetes, and they'd already seen pharmacy, they'd already seen nursing. I come in, they'd already seen the doctor, I have all these handouts, I have all this information, and I want to talk to them for 45 minutes, and about 3 minutes into the conversation, the tears just started to flow. And I went, you probably don't want to hear this now. It was definitely a eye-opening moment. That's not the time or the place. I can ask her what the biggest thing, or he, what the biggest thing is that they need to know right now. I can make a referral for an outpatient counseling session so that they can spend more time and that they can have multiple visits. When I was a student, the preceptor told me I can never go into a patient's room and leave before I've done a nutrition education. Scary. Nutrition educations can be quick. It can pertain to, I noticed on your lab work your iron stores are low. You need to make sure you consume foods that are high in iron. Red meat would be a good place to start. You need to try and raise that level. You can do it with food. Do you have any questions? That's a nutrition education. Depending on a particular lab, depending on if they ask me a question, it doesn't have to be 4 hours worth of, well, this is why your iron is low, and here's what the red blood cell is doing. It can be, you need to eat foods that have a lot of heme iron. Here's a list of foods that are high. Document it, chart it, you're good to go. Coordination of care would be, an example would be talking with the speech-language pathologist after I interviewed a patient who was choking on their food while drinking their orange juice. If a person's not safe to eat, I cannot feed them. I need to work with the speech-language pathologist on that, or any other type of referral that I need to make for the benefit of the patient. Food and nutrient intake, I can change all kinds of things when it comes to their diet. Population-based, this is new. It's dealing with more theoretical frameworks or population strategies. So this is a newer area that we're getting into now. I would say this is probably more public health based, but looking at total populations and trying to come up with some different types of interventions. So I plan my intervention by picking a priority, figuring out what needs to be addressed immediately, looking at the evidence or looking at guidelines that pertain to this particular situation, and then I come up with a nutrition prescription. I'll talk about that in a minute. Once I figured out what the nutrition prescription is, then I need to make sure it gets communicated to the whole team. I need to make sure that it is carried out, and I need to collect outcomes to see whether or not it's effective. So what is a nutrition prescription, you ask? A nutrition prescription is a concisely stated order that will benefit the patient. It can be 2,800 calories, it can be 112 grams of protein, it can be they need to increase their vitamin C, they need to cut down on their oxalates. Anything that is individualized to the treatment of that patient is called a nutrition prescription. We've used these forever. They've always been called a diet order. Some diet orders can be something like DASH, which is the dietary approach to stop hypertension. That could be a part of a nutrition prescription because I'm going to want to add how many calories that should be. I might want to add how much fluid that should be. I need to give a little more concise information. We always try to plan our intervention with food first. We want to feed the patient first. We don't want to give them a can of Ensure and hope they drink 3 of them a day. So keeping the idea of food first in mind, trying to figure out what they can do, what they will do, and make sure it's the recommendations that they need to be following. So I can intervene with anything that comes to food, I can intervene with anything that comes to enteral, and I can intervene with anything that comes to parenteral. As of about July 2014, the CMS, the Center for Medicare and Medicaid Services, finally gave dietitians the order writing privileges. Wow. So I should be able to go into any medical record, I should be able to say change the tube feeding to 75 meals an hour, I should be able to go in there and say change the diet order from a regular to a TLC. Yeah, you would think. It had, after CMS did this, there was honestly dietitian pushback. So we've begged for this, we've asked for this, we've wanted this forever, but now that we have it, all of a sudden, well, that's a pretty big liability. And there's a little bit of pushback going on. Actually, we have to work with our licensing laws. They don't say that we can't do it, but we also have to work with our medical facility. So that rule came down in 2014. In 2009, I had order writing privileges. The reason I had order writing privileges is because I went to my medical faculty and I went, look, I write a recommendation. It takes another 2 or 3 days before you guys see it or before you write an order for it. Meanwhile, we've lost ground. We're continuing to lose weight, or the PO intake is still poor. We're losing money here. Can I have order writing privileges? So when you start to talk money, when you start to talk about, we could decrease the length of stay, we could get patients out of here faster, we could prevent them from having kidney stones because we increase the hydration, money talks. So way back in 2009, I had order writing privileges. I could document this stuff in the chart all day long. They gave me a specific range of what I could do, a specific range of don't consider doing this. It was all filed legally, and I could do that in a medical record way back when. So dietitians have to work with their facility to say, I want to be able to do this. They have to set up training, I had to go through the same credentialing process that every doctor goes through. Even though I just applied for this job, I'd just gone through background checks and everything, I had to go through a whole credentialing process, but then it was done. So if we're really interested in providing the best possible patient care, we better get in there, we better be able to do this, we want to make things happen. So, after the intervention, then I need to monitor to see whether or not what I am doing is working. So, if I have a PES statement that states excessive energy intake because of poor food choices, and I know that because the food diary that I looked at indicated that they're consuming 600 more calories than they should be, and because the weight is 145% of what it should be, then the items there in red, I can monitor that food diary and I can monitor those weights to see whether or not what I did was this going to make any type of difference. Make sense? Got it all figured out? Ready to send me a consult? Hope so. So in summary, then, the whole nutrition care process is designed to improve the value of what dietitians do. It's designed to, we use evidence-based medicine. We don't say, well, you know, that paleo diet sounds kind of fun. Let's give that a try. And hopefully it's going to lead to some better outcomes as well. But it's a little bit confusing. A lot of pieces to the puzzle. Why do we want to take on this new process? Why do we think it's going to make any difference? Because there are absolutely benefits. There's benefits to myself as a clinician, more job satisfaction. There's benefits to improving the consistency of care. It's essential for me to track outcomes, to mine data or information in a medical record. I have to use standardized language. And it's very beneficial to have some type of a systematic approach. It's also beneficial because a very hot topic now is something called malnutrition. With using a standardized process, we're now more in tune to work or to collaborate with the whole healthcare team in order to solve the problem of malnutrition. Estimates for the number of patients that come into the hospital vary. I think one of your articles say they may vary from 15% to 65% or so. That's coming into the hospital. If you don't think they don't have malnutrition when they come into the hospital, I can almost guarantee you're going to get it while they're in the hospital. 95% of nursing home patients suffer from malnutrition. The topic is huge, and there's never been a standardized process to really tackle it. 1 in 2 patients that are hospitalized are going to leave with malnutrition. We have to do something to try and combat that. What we're working on now are, or what has happened historically or what's come about lately to try and combat this is a document that I gave you guys, the consensus statement. This is a joint project with the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition. And there's a lot of background, there's a lot of different history to this. It was in 1996 that the Joint Commission said that every patient needed to be screened. That started the process of looking at and finding more patients that really had some of these problems. In 2007, CMS, the Center for Medicare and Medicaid Services, kind of changed some of their terminology and their coding. And then something happened in 2011, I'm trying to figure out, the diagnostic codes or what have you started to become important. Even the CMS didn't like and up until this time, this paper that we finally published in 2012, there was no definition for malnutrition, if you can believe that. If you can believe that there's no definition for malnutrition, there wasn't. What this set up or what this left was for every institution to define it themselves. Some places would define it, well, a weight loss of 5% and an albumin of 2.5. Another institution would define it as poor intake and protein energy malnutrition. Okay? So every facility was at will to define it in any way that they saw fit. That was until, I think it was 2011, when even CMS didn't like the fact that we were using albumin in so many of these definitions, so they opened up and they asked for some comments. And that's when this document and several other documents started to finally come to fruition and to finally take place. So the article that you have there, the consensus statement, the reason I gave that to you was because there's a little diagram in there, about the second page. They do define malnutrition, and that is simply defined as nutritional imbalance. 2 words, definition, nutrition imbalance. But how we go about deciding that is based on this algorithm. So once a person gets referred to a dietitian, we can go through this process, we can go through this algorithm, and we can start to determine whether or not the person has what we call definition of malnutrition. The malnutrition, and there's also other information in that article that talks about the criteria. Well, if we can't use albumin, if we can't use some of the other things, protein energy malnutrition, how are we going to determine whether or not malnutrition exists? And we're going to do it based on the criteria that is listed in that article. The criteria is energy intake. Are they or aren't they eating? Are they eating greater than 50%? Are they eating less than or less than 75%? So there's specific criteria for intake. Remember, intake. Then we're going to look at their weight status. Are they losing weight? Are they losing 1 to 2% in a month? Are they losing 5 to 10%? What's the weight loss situation? That's the second criteria. The third criteria is loss of subcutaneous fat. And that also included some things like edema. It also includes muscle wasting as well. It also included in that particular area the hand grip strength. So that also became one of the criteria to use for whether or not a person has malnutrition. If you observe, if you look there, if you read that criteria and study it, it's never going to say if their albumin is less than 30. There's not a lab value, period, when it comes to a criterion for determining malnutrition. Glucose doesn't count, hemoglobin hematocrit doesn't count, albumin doesn't count. Whether or not they're eating, whether or not they have weight loss, and whether or not they have muscle or fat wasting are really the main criteria. So CMS didn't like that they were still using the albumin in a lot of these criterias. So they came up with this algorithm here. Is there inflammation present, yes or no? An example of a person that is starving, that has no inflammatory response, would be a person that has anorexia nervosa. A person that has anorexia nervosa has no intake, 3 green beans on Tuesday, and their albumin is perfectly normal. Their albumin does not decrease. So, and they also have no inflammatory response or no inflammatory markers. So we classify that now as starvation-related malnutrition. If they have the inflammatory response going on, then it could be either acute or chronic disease-related type situations. So this is now the algorithm that is being used to assess for malnutrition. There's the criteria. What's missing? Albumin. The reason it is missing is because there's something called a negative and acute phase proteins. These are the visceral proteins, and negative acute phase proteins, those consist of albumin, prealbumin, transferrin, retinol binding protein. Positive acute phase proteins, on the other hand, are C-reactive protein and ferritin. When the inflammatory response begins, my liver, which is normally manufacturing, that's what the liver does, it synthesizes albumin all day long, until the inflammatory response starts. Then it shifts, it re-gears, and it's normally producing a negative acute phase proteins. Once it needs to realign or start generating C-reactive proteins, the synthesis of albumin ends. So in a inflammatory response, the negative acute phase proteins go down. That's why they are called negative. So the minute inflammation starts to happen, C-reactive protein, guess what? It's going up. So C-reactive protein is a positive acute phase protein because it rises. The liver can't manufacture all of this at one time. It has to prioritize. So albumin is going down. This person's eating all day long. Their nutritional intake is fantastic, and their albumin decreases. But if you look at their labs and you start to trend this information, their C-reactive proteins going higher and higher and higher. So we can use albumin as a marker for mortality and morbidity. We cannot use albumin as a marker of nutritional status for this very reason right here. Make sense? Clear? So you're never going to document that the albumin is low, so eat more protein, right? You can order that consult. I'll come in and help the person eat, no problem. But I'm not going to base it on how many cans of Ensure that they're going to drink. All right, so it's very important to diagnose malnutrition correctly. The next article that I gave you, I call it the Tappan article. It is written by Kelly Tappan, who talks about the benefits of the interdisciplinary team when it comes to diagnosing malnutrition. When we have an interdisciplinary team, we can help reduce the length of stay. We can help reduce, hopefully eliminate some medical errors and things like that. So that article points out several different things that by cutting down on the malnutrition, by engaging all of the healthcare professionals that need to be there, we can make improvements. But the most important thing when we start diagnosing malnutrition, and malnutrition is a standardized language, it is in the clinical domain, so a dietitian can diagnose malnutrition because I can do a lot to go about and fix it, but CMS is not going to base their revenue on my saying that. So they don't look at my nutrition diagnosis in order to reimburse the hospital for this particular condition. Once we diagnose malnutrition, though, we can improve outcomes. A big kicker here, when I said money talks, guess what? We can really improve revenues as well. So the last article that I gave you, it talks about the diagnostic codes. The hospital needs to have a policy on malnutrition. If a screening process leads to that registered dietitian doing a nutrition assessment, the whole PES statement, the whole 9 yards, and the dietitian does come up with malnutrition, or the dietitian says to the doctor, you know, you've really got a malnourished patient. We need to document this. So whether or not I use that standardized language or not, I may be way more concerned about that weight loss and really want to focus and intervene on that weight loss. But if I have a conversation with the doctor, if I somehow get to him and say, please document in your note malnutrition, guess what? The revenue for the hospital goes way up. So if there is a team looking for this, if you have 30 to 50% of your population with malnutrition, why do you not look for this? Whether it's more money or not, why are we not trying to fix that? So yeah, it's nice, the hospital, CMS has a bunch of codes now, and we can generate more revenue. The article that I gave you from Parrish, I call it the Parrish article. This one, Coding for Malnutrition, what the physician needs to know. If you look on page 63, table 7, it shows you examples of a GI obstruction. So the estimated revenue was $4,402. Once they include malnutrition, the revenue went up to $5,777. That's an increase of $1,375 that the hospital stands to gain because of the diagnosis of malnutrition. Second example, you can read for yourself. The third example, they have cirrhosis and alcoholic hepatitis. So the codes that they use, they would generate $3,505. If they include malnutrition, that revenue goes up to $6,259. Or I'm sorry, the revenue goes up to $9,700, an increase of $6,200 that the hospital stands to gain. Wow, that's pretty big. That's pretty big. But it's not a one-person job. It's not just the dietitian recognizing it. The physician is also going to have to document it. If I'm going to write the nutrition diagnosis of malnutrition, I'm going to want to do something about it. I'm going to want to fix it. I'm going to want to try and prevent that weight loss or increase that PO intake or any of those characteristics for the sake of the patient. And then you also have to work with your coding people within the hospital in order to make sure that they code it properly, and that's the coder's job. Hospitals hire coders to do just that alone. So I don't have to know any of those codes. I couldn't tell you what a CPT code for, or I could tell you what any of that is for malnutrition. But I can tell you from a clinician standpoint, it shouldn't have to happen. One of the slides, or maybe one of the articles, talks about an article back in 1972, the skeleton in the closet. Was the first time they really talked about malnutrition in the hospital. 1972 is how many years ago? It hasn't changed. It's not fixed. It's still a huge problem. So that's why us working together as a team, picking up this type of information, including the patient in the care plan, what they can increase, what they do want to what they can do to help prevent weight loss, all of this can come out with definitely beneficial or better outcomes than what we have today. So that's what I just referred to in that article. In summary then, nutrition is definitely a very important piece in the healthcare puzzle. How many of you have had Nutrition 101 in any of your schooling? One more time. That's probably over half. How many of you wish you would have had nutrition? Is nutrition required in medical education? No, it's not. How sad is that? How sad is that? Trying to get my hands on an article that I just heard about the other day. I haven't got it yet, but it said that Osteopathic Hospital in Ohio surveyed their students. 68% of the students felt that nutrition needed to be included in patient care. 55% of their students couldn't even pass a Nutrition 101 quiz. And yet, we're in the healthcare business. That's what we do. Registered dietitians use the nutrition care process to focus on that PO intake, to focus on those criteria, and to hopefully prevent deficiencies. Prevention is really the best medicine if we started much earlier. Dr. Latassi and I were talking about, do you guys know how to cut up a chicken? We used to, I mean, this is how we learned to cook as kids. Our mothers taught us how to cut up the chicken and, you know, you fry them and all kind. We've lost an art today when it comes to how to cook and what to fix, and we go through the drive-through and, I won't get on that soapbox, I better wind this up. We really do need to depend on each other to do what we all do best. We all have specialized training, we all have great things to offer, we can all provide better patient care if we're doing it as a team. But one-on-one, ordering a consult and never bothering to look at what they do or look at those recommendations, you know, we're spinning our wheels, we're wasting a whole lot of time. If we work together as a team, we can all provide better, safer care to that patient. So I think I got a little time for questions. Hit me.
I had a question about the difference between an associate's degree in nutrition and the bachelor's. What's the difference? What do they do difference? Is there
An associate's degree is usually a 2-year degree. A bachelor's degree is usually a 4-year degree.
Yeah, like I know that part, but like on the aspect of whenever they graduate, what do they do different?
An associate's degree, you cannot sit for the national registration exam. You
Okay.
could never get that credential CDR.
Okay.
Now, in all of this master's, moving to this master's level stuff, we're taking a lot of what the 4-year degree used to be and putting it into the master's level. This is where some of us are pretty upset, and we're taking that 4-year bachelor's degree and kind of turning it into those wellness coaches and a lot of those other type situations. Those people will not be able, even though they've got a 4-year bachelor's degree, those people are not going to be able to sit for the registration exam.
Okay. So with an associate's degree now, we won't encounter these nutritionists in the hospitals or anything in the medical field. They'll be more like at gyms and places like that.
Right.
Is that?
Exactly. Exactly. What else? What other questions do you have?
I wrote down several. Since those that are in the outpatient, what would be high-risk behaviors or things that they would see that should prompt a nutrition consult for malnutrition? We can prevent it before they go into the hospital. What kinds of things should they be looking for?
Wounds, a lot of wound care clinics, you'll see malnourished patients all the time, and wound care clinics usually don't have an RD. So it would be nice to refer them to probably somebody in private practice, or maybe work with the wound care clinic in order to get the RD there. We could solve a lot of issues. HIV population, we worked with there's an HIV clinic on the OU campus. They finally hired an RD full-time. instead of trying to, they have so many medication problems, they have so many diarrhea, pneumonia, all kinds of stuff. That would be another outpatient possible malnutrition situation. Renal patients that are trying to prevent dialysis or headed for dialysis can get reimbursement from seeing a registered dietitian. The minute they move into the dialysis clinic though, the dietitian isn't going to get reimbursed for that coverage anymore because a renal clinic is required to have an RD there. So renal, HIV, what was the first one that I mentioned? Wounds. And then there's just overall outpatient situations where there might be a lot of nutrition deficiencies nobody's looking for. Doctors don't have time, pharmacists don't have time. They don't have any idea why they keep having, this rash, or they don't have any idea why they keep having problems over and over again. So really, when you look at the numbers for malnutrition, they're scary. And malnutrition is not just weight loss, it's weight gain. You can be 100 pounds overweight and be malnourished if it's from, all carbohydrate, so.
Are your data this true also for children? You said 1 in 2 hospitalized patients coming in. Is that true with children as well?
I would say that for the adult population. I don't know that that pertains to children. I'd have to go check a little research to answer that one. But I can see if a child is well, they're probably not going to have to come to the hospital. There's got to be some reason we're coming to the hospital. If it's a one-time, mom got word she had a fever, a one-shot deal, then it's probably going to take care of itself. But children that have to come in, we have a whole children's hospital for cancer and metabolic disorders, a whole lot of different types of situations that children encounter.
How long, sorry, go ahead. Go ahead, baby.
No, that's okay.
Follow up. No, go ahead. I gotta write this down.
Do dermatology clinics employ RDs or do they work?
Nope, got a dermatology tomorrow at 2:40 and they don't have an RD there. They do not. At least not the one on OU campus. But I could ask them to refer probably. But it might be a suggestion. What, you want to go to dermatology?
No, I was just wondering since a lot of nutritional deficiencies have like skin manifestations.
Absolutely. Absolutely.
I have a question about the cost, because if the cost goes up, that's on the patient, right? So like an extra $6,000, so as of, no, it doesn't.
That's what Medicare, or that's what CMS is going to reimburse. That's not on the patients. Yeah.
Okay, so,
Insurance company or CMS or, no, that's not on the patient.
okay, so would we have to ask for the patient's like permission to have you consulted in to discuss with them anything about malnutrition?
In
Or
a
do we
hospital
just do
setting, no.
Okay,
A dietitian in a hospital setting does not file for reimbursement. My time, my effort is considered room and board. So in a hospital setting, you may order a consult and the patient may not want me to be there, so I have to document consult ordered, patient not interested. But it's not going to cost the patient another visit. All of that is, food is considered room and board, so they don't pay for my services there. One of the biggest reasons people won't go to the dietitian is because a lot of times it's not covered. So we're trying to make massive efforts now to work with different insurance companies. We say that what is covered for reimbursement for dietitians is diabetes and renal disease prior to dialysis. That's what's covered by Medicare. If you work with insurance companies, you can ask to be covered on all different types of plans. But that requires an aggressive RD that says, get me in the picture. They even covered, or CMS even said that now obesity is covered, but obesity education provided by the doctor is covered, not obesity provided by the registered dietitian. A smart dietitian is going to work with a doctor though and say, get me into your service, I will provide this education, you file for it, and I get a cut. So there's all kinds of different situations, but My dander goes up a little bit when people say, well, you know, I have to pay for your visit, and I say, nice manicure you've got there. So, you know, they'll pay for a manicure and a pedicure, but they don't, if it's out of pocket, they don't want to pay for a dietitian. Whatever.
How long does it take for a patient who comes into the hospital in a good nutritional status to become malnourished if they're there long-term? What came to my mind is that if people are assessed initially coming in, but other things, if they're there for a while, then other factors are going to distract everybody. So where is the critical time or times where people ought to go back and look at, we need to make sure they're eating or have good nutrition status?
If somebody went through the first screen, they came in for elective surgery, even elective surgeries can go bad and problems and complications. If they come in and they don't trigger a nutrition consult at that time, most hospitals have a rule that on the 7th day, they need to be seen by the registered dietitian. If they're still there after the 7th day, for whatever reason, get the RDs to set their eyes on them. That's usually length of stay 7 days, whether they triggered or not, we would go see them. What else?
Is there any screening you would recommend for outpatient providers? You know, like I said, most of those questions we don't end up having time to ask.
I like the determined checklist. It's usually meant for the elderly, a little bit older. The nutrition screening questions that they can put on the hospital screening, they limit you to 3 questions. But a lot of times in the outpatient setting, the patient may be sent a packet of information to fill out, like health history and all of that, prior to the appointment. I was really bad. I had an appointment with the doctor. They said you have to do all of this online before you come in, which is fine. That's no problem. I can answer 5 or 6 pages worth of all this information and all these questions. Then I got to the doctor's office and they said, oh, we need this information. I said, no, you don't. You've got this information. I'm not filling it out twice. But I would say maybe 5 or 6 questions. Any major diseases that might require nutrition information, any loss of appetite should be a big trigger, any recent weight loss history, that should be a big trigger. So you could probably keep it to 5 or 10 questions that if you're seeing things there, hopefully the outpatient would have a dietitian to set eyes on and go from there. A few questions. I mean, we're so inundated with paperwork though. I mean, I wouldn't do a long, detailed information, but simple questions. That's why I like that health or determined checklist. You know, you come up, if you score more than 6, you know, you probably need to go see an RD. That type of thing. What else?
I would like your opinion on the kind of the new thing that's going, well, it's been around for a while, but the recommendations now to eat 20% under your recommended weight that is associated with longevity, and incorporating more fasting times in a week or in a month.
Permissive underfeeding is a topic that's addressed a lot of times in the ICU, particularly. I think there's a time and a place for that. There's been multiple times people in the ICU, even though we've always said they're hypermetabolic, that they probably need more calories. If they're on a machine that's breathing for them, honestly, they probably need less. And when they're in intensive care or things like that, we can do more damage by overfeeding than we can by underfeeding. So there's something called refeeding syndrome, where patients are fed too quickly because you got them now, let's feed them. That's not necessarily a good idea. There is the school of thought, and I'm somewhat familiar with, I heard you mention the Seventh-day Adventists. They probably have the healthiest diet out there. They have the less cases of disease and all kinds of things, but is that because they don't smoke, or they don't drink, or they eat really healthy? We're really not sure. But there is a school of evidence or a body of evidence out there on permissive underfeeding for critical care, but also I know there's that school that thinks we really should eat less and have less cancer, less all kinds of things if we're at a healthier weight. I'd say individually, on a case-by-case basis, it'd be worth looking into, definitely. We just hired, one of the latest hires in our department was a guy who's doing calorie deficit research. So he's probably more of an expert on it than I am, but there's a whole lot of them on that campus that's looking at energy deficit is what they're calling it.
What do you think about coconut oil?
What do I think about coconut oil?
Yeah.
I think it is a saturated fat. The advantage of a coconut oil that it also contains some medium chain triglycerides. Saturated fats, every single bond is connected. A medium chain triglyceride only has 6 to 12 carbons. A long chain triglyceride, which most saturated fats are, have 12 or more carbons, up to 20, 22. What makes coconut oil a benefit is that the medium chain triglycerides make it easier to digest as far as the digestion goes. The definition of a saturated fat is anything that is solid at room temperature. If you look at coconut oil, it is solid at room temperature. It's a saturated fat.
There's nothing magic about it?
No.
Great, okay. Thank you.
No. Is that what the answer you wanted me to say?
Yes. Yes.
Thank you. That ends our discussion this morning, thank you.
Saturated is solid at room temperature. Solid is solid is solid. So,
That's beautiful.
but my other piece of advice to that is there is no good or bad food. It's not what you eat, it's how much. If you change your entire diet to be nothing but coconut oil, then you're probably looking for problems. If you use it once a year on popcorn treats or, if you don't make it a mainstay, then there's nothing we can't do. Our problem is not what we eat, it's portion control. We have portion distortion. So if we're gonna eat, the whole thing of Rice Krispie treats that we use coconut oil on, that's the problem. It's not the coconut oil. So, saturated is saturated is saturated. What else?
Another. So since I'm in PA school, we stay up and study late a lot, and eat at what I would consider inappropriate times, late in the night. How much do you think that really impacts how your energy is the next few days? If you stayed up, for example, I stayed up till 4 in the morning on Sunday, and then I slept, a few hours, and I woke up at 6 or 7-ish, and then kept going. And I ate an extra meal. How much do you think that's gonna impact me for the rest of the next few days? Is that resetting my metabolism? Because I'm so hungry today.
And you want that. I go, my heart pumps 24 hours a day. My gut digests 24 hours a day. I mean, I can metabolize regardless of when I eat it, even if I go and lay down. The digestion process is still gonna go take place. So the energy is there. You're still gonna go through glycolysis. You're gonna go through all of the pathways regardless of what time that you eat it. If by adding that extra meal, you're adding extra calories and not doing anything to burn them, then it could lead to weight gain if you continue to do this on a daily basis. If you're so tired the next day you can't exercise or you spend a longer time in bed, then that's not going to be a good situation either. My advice would be to get your rest, study in the morning. No test is worth it. You're gonna pass.
It's unavoidable. It's just strange. I wasn't sure if, because your body's normally asleep at that time, if your metabolism is no, I'm gonna slow down even though you're hungry. You know what I mean? I was just unsure if your metabolism follows a cyclic kind of pattern.
There's a lot of research on people that work nights, what jumps out at me now is the melatonin, though. The melatonin, when things get dark, wants you to slow down, wants you to stop what you're doing and go lay down. Honestly though, energy-wise, I think a calorie is a calorie. It doesn't matter whether you eat it at 6 o'clock in the morning, 8 o'clock at night, 12:30, 4 or 5 times a day. If you know those type of situations are gonna happen, I mean, I try and have more light snacks or things that aren't gonna add on major calories, you know, even a hot tea, something like that, to try and snack on when I'm studying. But trust me, the test is worth it.
In 10 years.
Even
my
Dr.
doctor
Latowski's
says,
test.
"It's worth it." I think is what they would feel.
Nobody is going to remember what you scored, and you know what? Nobody's gonna care. The patient's gonna not say, what did you get on that exam?